Dr. Donna Gourlay. In this session, we'll review the components and characteristics of the U.S. healthcare delivery system, which is an overview of Chapter 1 of the textbook, Delivering Healthcare in America, A Systems Approach by Shi and Singh. There are 4 components of our healthcare delivery system, illustrated here. You will need to understand these in order to better understand healthcare in the U.S. While 3 out of 4 of these items revolve around money, they each mean something different. The first is finance, which is at the 3 o'clock position. This is the promise of funding for healthcare services. For most Americans, healthcare is financed by employers. Other sources of financing include the government and private individual funding. Insurance is the second component of our healthcare system at the bottom. Insurance covers catastrophic risks, determines the package of services that the insured is entitled to receive, and how and where healthcare services can be delivered to those whom they cover. Insurance can come from private or governmental organizations. Delivery of healthcare is accomplished by providers, including physicians, therapists, nurses, dentists, and includes settings like inpatient or hospital, outpatient or ambulatory, and equipment suppliers. After healthcare is delivered, reimbursement or payment must be given to cover the costs. Payment comes from the organizations who provide insurance and likely will include the individual for out-of-pocket expenses like co-payments. All of these components ensure that those who need healthcare receive it, and those who provide it are reimbursed. But is that really true? Access to healthcare services is an issue of which we will discuss in another video segment. Until the 1990s, healthcare was fragmented between components that we just discussed: finance, insurance, delivery, and payment. As healthcare costs continue to spiral upward, insurance companies set in place a system called managed care, which was designed to control healthcare costs through better integration of these functions for utilization. The components of managed care include integrating delivery of the healthcare components for the purpose of achieving efficiency, employing mechanisms to control or manage utilization of services, and identifying the price for which these services are purchased. Managed care is packaged as a health plan, which contracts with specific health systems for types and costs of services. These are called Health Maintenance Organizations, or HMOs, and Preferred Provider Organizations, PPOs. For example, an HMO, like Blue Cross, would contract with Loma Linda University Health to provide specific services for its members. This is also called fee-for-service. A PPO like Kaiser Permanente would require its members to obtain services within their system. Otherwise, services either would not be paid for or the coverage would be significantly reduced if the service was received outside of the system. Now, let's look at the 10 characteristics of the U.S. healthcare system. First, there is no central agency which governs or administers healthcare in the U.S. That's pretty amazing considering the size of our country and its economy. Our healthcare system is largely privatized for finance and delivery of services. However, without oversight, how successful do you think a market-based healthcare system could be? The second characteristic is that access to services is based on whether a person has the ability to pay, either through private insurance, private funds, or government insurance. One caveat is that under federal law, hospital emergency departments cannot discriminate on whether or not a person can pay for services. They are required to assess a patient and render medically needed services. Often these services are written off as part of doing business, particularly if the organization is private and non-governmental. This is why emergency rooms are full of non-critically ill patients. It is often their only point of access to health care. Even though health care is privatized in the U.S., which means it is not controlled by the government, it does not really exist in a free market. This is better known as an imperfect market. In a free market, buyers, or patients, and sellers, or providers, act independently, allowing freedom of choice through basic economics. However, in reality, insurance plans are the intermediaries between the patients and the providers, and end up controlling the system and shifting power away from the patients, who should make informed choices based on economics. The fourth characteristic of our healthcare system is that third-party insurance agencies act as intermediaries between the patients and the providers, which we just spoke about in the previous slide. With multiple payers, delivery and reimbursement become a nightmare and increase administrative costs through the billing and processing of claims for payment. The sixth characteristic, because there are so many players in the healthcare system, each has its own self-interests. This limits the balance of power and the effectiveness of healthcare reform. Because the U.S. is a litigious society, defensive medicine is often practiced to minimize the risk of a lawsuit by a patient against a healthcare provider. This means that diagnostic tests and other services are overutilized, which drives up the cost of healthcare. It's hard to dispute that the U.S. has the best medical technology in the world. And with this technology comes a demand to utilize it, both from the providers and the patients. Healthcare is developed along a continuum of service settings, from preventive care to end-of-life care. Shifting healthcare services away from the expensive hospital setting also reduces costs and improves outcomes for patients and the healthcare system. Finally, quality in patient care has become an expectation and is now considered attainable. Continuous quality improvement, or CQI, is a term that started in the manufacturing industry, but has been embedded into the process of healthcare delivery. Over the last decade or more, quality, often in the form of patient outcomes, has increased, making healthcare in the U.S. better. As I mentioned in the previous slide, healthcare is delivered along a continuum of services. This slide illustrates the types of healthcare services and examples of settings in which care is delivered. You can see that the hospital setting, which is the most expensive delivery setting, is reserved for subacute and acute care. Other types of care are shifted outside of this setting into the community and ambulatory settings. The benefits of these settings include better delivery of care, improved patient outcomes, and reduced costs of services. Now that we've discussed an overview of the U.S. healthcare system, let's look at how other developed first world countries deliver healthcare services to their citizens and residents. International healthcare is structured in typically one of three ways. A national health insurance system, as seen in Canada, is financed by the government through taxes, but patient care is delivered in a private rather than governmental setting. Great Britain has a good example of a national health system where the government oversees, delivers, and pays for health care within the country. Finally, a socialized health insurance system occurs when the government mandates contributions from employers and employees to finance health care. Germany is a good example of socialized health insurance system. Within it, the government controls the system, including insurance and payment functions. However, the distinct difference between socialized and national health insurance is that funds are collected by private, nonprofit insurance companies, which are responsible to pay for services. So here's a question to consider. Which type of healthcare system would work best in the U.S., considering the characteristics that we've just discussed? The Affordable Care Act, or ACA, of 2010 was created to help ensure those who either don't qualify for government insurance or can't afford to pay for private insurance. However, that reform was placed on hold and didn't have the time needed to implement these changes. So, what type of healthcare system do you think would work best in the U.S.? We've looked at healthcare within the United States and other first world countries. Now let's compare first world to third world healthcare needs. On the left are characteristics of first world countries. They represent a small percentage of the global population, yet they have an excess of hospital beds and physicians, and by default, a higher utilization of cost of healthcare. In addition, changes in vaccines, food and water sanitation have realized a longer life expectancy for their populations. Now on the right, third world countries are characterized by opposites. They have a significant proportion of the global population and disease burden, yet a tiny fraction of healthcare spending. All of these combined with poor sanitation and vaccination rates lead to shorter life expectancies for these groups. In addition, these countries rely on global assistance from first world countries for healthcare delivery and financing. If that funding decreases, what happens to the disease burden and life expectancy, along with healthcare spending? Do you think these factors decrease or increase? This has been a very brief overview of the U.S. healthcare system, a review of other countries' healthcare financing systems, and a comparison of health needs between first and third world countries. I've worked for more than 20 years in healthcare, and I've seen some things improve, such as quality of care, patient safety, and technology. However, we have a long way to go to improve national health outcomes. What do you think is needed to improve healthcare within the U.S.? One thing is certain: healthcare reform in our country will demand those in power to relinquish control for the benefit of others. In addition, public health must do a much better job of showing the financial benefit of prevention so that others, like insurance organizations, will contribute toward the cost of implementation. As a future public health professional, I challenge you to think outside of the prevention box, beyond vaccines and screenings, and think about how our communities are designed. How could a community's design contribute to better health? Here's a hint. It involves placement of services and connectivity to those services beyond vehicle transportation. And that is the future of public health. Transdisciplinary health involving city planners, insurance organizations, public health and healthcare professionals, business owners, industries, and the public. Some communities have already started this revolution, and I encourage you to investigate what spurred them to implement a different design for their community. I think you'll be surprised what you find. I'm Dr. Donna Groulet. Thanks for watching.